Hello, I'm Dr. Moushegh Najarian, and I'm happy to participate in this international symposium on mental health needs in children in Armenia. I would like to compliment and congratulate Drs. Armen Sohoyan, Armen Danayalian, Adh Behavior, and the entire staff that have worked so hard over the last several months to prepare this, including Anna and Liana, the technical people. Without their help, I certainly would not have been able to do this. I also think it's fitting to do this in honor of Dr. Konstantin Danayalian. I knew Konstantin in my early earthquake work days in the 90s. He was a pioneer in psychotherapy, in teaching it and practicing it and leaving his legacy, especially during the Soviet times. And I'm sure he is proud and would be very proud of his son Arman spearheading this very important symposium. So I want to speak to you about attention deficit hyperactivity disorder over the life cycle, ADHD, because it used to be thought that this condition matured with puberty in late adolescence, but we know now it continues on into the adult life, and there are many sequelae when it's untreated. I like to begin my presentations with a conclusion. And what is ADHD? It is a neurobehavioral disorder with a complex etiology. It has a clear neurologic basis, a neurobiologic basis, and it has a strong brain genetic component. It is a developmental condition of the brain. ADHD affects millions of people, boys and girls, mainly boys, persists throughout the adolescence and adult life into a high percentage of cases. It can have a negative impact on multiple areas of functioning. The good news is there is treatment. 85 to 90% of the symptoms are mitigated with treatment. We have very few conditions in psychiatry that has a 90% improvement rate. That's the good news. The bad news is the medication for this treatment is not available in Armenia. It's prohibited, and that doesn't make sense to me. I hope there are members from the health ministry and the parliament that supervise medication in Armenia to understand the treatment, the medication treatment for this stimulants are safe and they're very effective, and there is absolutely no reason they should not be available in Armenia, and it's inexpensive. And you'll understand more when I finish my presentation. Dr. Arman Danayalian will talk about treatment and hopefully support some of the same things I'm saying. So it is a neurodevelopmental condition with a complex etiology, and it affects millions of people and have a negative impact on various areas of functioning. So what is it? What is the ICD-10 criteria? It's a persistent pattern of inattention and or hyperactivity impulsivity that interferes with development by either inattention with 6 or more symptoms for 6 months that must interfere with functioning, or hyperactivity, impulsivity, 6 or more symptoms, which I'll elaborate on, for 6 months that interfere with functioning. It must be present before age 12. You don't get ADHD at 15 or 18 or 20. It's a developmental condition that most often begins in the school-age child, sometimes even in the nursery school child. It has to have a clear evidence that interferes with functioning and quality of life in 2 or more settings: their social life, academics, or occupational life. And it cannot be present with other disorders such as schizophrenia, anxiety, substance abuse, or autistic spectrum disorders. An individual with ASD may have similar symptoms with attention, hyperactivity, poor trouble with focusing and concentrating, but this rules against an ADHD diagnosis. Although medications may still help those symptoms, you can't have ADHD and schizophrenia at the same time. Schizophrenia basically rules out attention deficit hyperactivity disorder. What are the inattentive symptoms? Unable to pay close attention to details, makes mistakes, difficulties sustaining attention in play, lectures, reading, person doesn't listen. Their mind is elsewhere. They can't follow through or fail to finish chores or duties at work. They're disorganized, difficult to prepare reports. They lose things, books, pencils, tools, easily distracted, forget appointments. Now, many of us might have one or two of these. You have to have 6, and it has to interfere with functioning. What about the hyperactive impulsivity? People often wonder, what's hyperactivity? Dr. Stella Chess, a very famous child psychiatrist in the 40s, 50s, right up to the early 60s in New York, said hyperactivity is that child who looks different from the other children. It's that easy. You have a classroom or a nursery school of 20 children. The hyperactive one is bouncing off the walls and noticeably different. They fidget, they tap, they leave their seat, they can't sit still, they run around and they climb. It's very difficult to enjoy and engage in leisure activity. They're on the go and they're driven like a motor. I often say their carburetor is set higher than normal. You know, when you put a car and drive and it goes 10 miles, 15 miles an hour, that car has ADHD. There's excessive talk, there's motor mouth, blurting answers, interrupting. But again, you need 6 of these, not 1 or 2, which many of us may have. So what are the causes? Structural, which we'll go into in more detail, hereditary, genetic, and complications of pregnancy. Premature children are more at risk for ADHD. A cesarean section delivery is more at risk for ADHD. Nicotine exposure. Mothers who smoke during pregnancy are at higher risk and have a greater percent of children with ADHD. Now, this never would have been a problem in Armenia. In the early 90s, when I worked here for the earthquake, mothers never smoked. But today, many women do smoke, and that's a risk for ADHD. Let's talk about the structural changes. First, the incidence. The incidence on the average is 3 to 5% in children, adults 3 to 4%, and males predominate 5 to 1. And it's pretty similar in very congested urban areas like New York. The percentage might be higher, maybe 4 or 5, but in other places it's less. New York City, it's almost 4.5, but it's the same in the world, roughly 3 to 5. India is maybe 4.5. I'm not sure how Ukraine got up there to be so high, but it's pretty similar throughout the world, but basically 3 to 5% of the population. Structural causes. Clearly, there's a smaller amygdala with abnormal connectivity to the prefrontal areas. The connections to the executive functioning areas are where the delay is. There's cortical thickness in analyses in adults and volume reduction. Here's an example of cortical thickness in the prefrontal area and the medial cortex. Here's an example of where there is thickening, cortical thickening with less volume in the dorsal lateral prefrontal cortex and in the cingulate area, thickening and less volume. Another example of thickening with volume reductions and thickening that affect connectivity. This is an important slide of a normal ADHD brain and an ADHD brain, where the dorsal anterior cingulate cortex fails to activate in the ADHD brain. This individual was given a task of reading and addressing some complex intellectual activity. The dorsal anterior cingulate lit up. The ADHD brain did not light up. That's why stimulants work. They help normalization and stimulating some of the areas that require activation. This shows decreased correlations and connectivity. Here's a normal brain with the prefrontal and the medial areas, normal thickening, normal volume. Here's where an ADHD brain, there is abnormal thickening with less volume, and the connectivity is shown here where there's a deficit. This brain is deficient in these areas where there's cortical thickening and less volume. Similar with the amygdala and prefrontal cortex circuitry. We'll skip over this. Genetically, there's a family studied in Colombia, Pisa, Colombia, and there was 18 extended multi-generational families, genetically loaded and densely segregated for ADHD, highly comorbid with conduct disorders, nicotine dependence, and alcohol abuse. And the linkage is with the DRD4 gene. Clearly, structural changes in ADHD brains and genetic differences in the chromosome. What's the cause of the disorder? Younger individuals, children and adolescents, are more hyperactive, impulsive with inattention. But over time, the hyperactivity impulsivity diminishes and we see more inattention. Here's another slide showing the same thing. With children with motor hyperactivity, aggressiveness, low frustration tolerance, with impulsiveness, but as we get older, it shifts to being easily bored, impatient, and restless. The key for clinicians is considering the impact on the quality of life. There's an important slide over 16 years, from 10, really from early on, 5, right up to after 30. The red line shows continued functional impairment. 65% of individuals showed continued functional impairment at 30. Their full diagnostic criteria may diminish to only 15%, but impairing symptoms, impairing in functioning, over 70% after 20. There's a perfect example of what happens in the life course and the lifestyle of an individual untreated. Let's go through the child right up to adults. What's ADH behavior like in the preschool child? Well, they're busy running, climbing excessively, different from the other 18 and 19 children. Remember what Stella Chess said. Keep it simple. The child that looks very different is the hyperactive one. They're impulsive, and they don't learn from experience. They tend to be accident prone because they keep doing things they shouldn't. They keep climbing, they fall, they get hurt. There tends to be more accident proneness in children with ADHD. They're aggressive and can't share. The teachers are always watching them because they're afraid they don't get hurt. They're wandering, they touch things, they have trouble with quiet time, and they have difficulty to soothe themselves with activity. What about the school-age child? They're impulsive and hyperactive. They're inattentive with uninteresting tasks, but they can stay for hours on a video game. And that's a whole other story. Dependence on video games and screen time. This is really a problem in the US and really around the world, and I'm sure in Armenia, with the pandemic and schools being taught remotely, 5 or 6 hours on the screens added to children with ADHD. They may meet the criteria, but their brain developments are different. They developed it from an external sociologic situation, being forced to be in a classroom or be at home in front of a screen for 5 or 6 hours a day and then play video games for 2 hours a day. That would cause any brain to begin to deteriorate. They begin to have difficulty socializing. They do poorly in school. They don't feel good, so they become disruptive. You should feel good by doing good with your schoolwork, but if you can't pay attention and learn, you're not going to feel good. So how to feel good? They become the class clown, and they're always in trouble. What about the adolescent? There's a decrease in the motor activity, but increase in internal restlessness. Remember, what are the signs of adolescence? It's a psychological concomitance with puberty. Puberty is the body changing. One develops their sexuality. Boys have wet dreams. Girls have their periods. They begin to have sexual feelings and a sense of sexual identity, and this contributes to an internal restlessness with poor frustration tolerance. They're bored. They're looking for novelty. They're looking for exciting things to keep themselves busy. And once again, their school grades become poor. They become socially isolated. and they become sensitive to peer approval. So they start hanging out with other disruptive behavior problems. They can have antisocial behavior, mood swings. Dr. Biederman, Joe Biederman at Harvard, has done studies, and 15% of children with ADHD in adolescence, when it doesn't begin to slow down, develop bipolar disorder. People in their 20s with bipolar disorder demonstrate at least 20% start with difficulty in adolescence. And there's a clear correlation with a subset of ADHD children, when there's a strong family history, go on to develop bipolar disorder. What about adults? They're less hyperactive, but more subjective restlessness, more impulsive. They get involved in schemes. They get involved in money deals. They gamble. They get involved with romantic relationships. They have extramarital affairs. Continued difficulty with focus attention, difficulty with multiple tasks and responsibilities, inability to complete tasks, difficulty planning. They have affective instability, can be explosive, leading to abuse at home and substance abuse and marital issues. So this is a very important slide to show comorbidity. The green is the incidence of various emotional problems in children and adults. Major depressive disorder, low percentages, bipolar, even less. Simple phobias, these are the anxieties, OCD, conduct disorder, and OCD. The green is the average population. The red shows the increased incidence. Look at this, almost 8 times more oppositional defiance disorder, 5 more times major depressive disorder with untreated ADHD. The psychological consequences, the suffering, the financial loss is immense with untreated ADHD. The comorbidity is quite impressive. And if there's any one slide the health ministry or the parliament people should take is this: the increased incidence of various issues, alcohol, smoking, oppositional disorder, behavioral problems, legal issues, major depression, are all 3 to 5 times more in untreated ADHD. Here's an example of college graduates. Less than 40% of students with ADHD graduate college. Almost 85% of individuals without ADHD graduate college. Here's an important slide, and when I was sharing slides with Dr. Danielian, I was pleased we had similar slides. This is the major depression. This is major depression without treatment. It's almost 3 times more. Treated major depression, untreated major depression. Multiple anxieties, 5 times more when it's untreated, and bipolar disorder. The importance of this is that the incidence and comorbidity is much higher when you have untreated ADHD. Here's substance abuse in youth. Controls, maybe 7% of youth have problems with substance abuse. When they're treated, it improves. Unmedicated, it's 6 times more in unmedicated ADHD individuals that abuse alcohol, marijuana, and other substances. When you medicate them, it's not statistically that significant between the controls and the medicated ADHD, but untreated ADHD, it's a disaster and a catastrophe. It's unnecessary. So we look at functional impairment. That's the key. Treated ADHD individuals have higher success in high school and college. They're more employed. Their household income is higher. They get fewer accidents. The incidence of alcoholism is much higher in individuals who are not treated. Domestic abuse is much higher in individuals with ADHD and not treated. these are the areas that the clinician must look at and evaluate. And it's a strong signal for treatment. So my conclusion that I begin with, ADHD is a neurobehavioral disorder. It's a developmental condition with a complex etiology. It clearly has basis with delays in brain functioning, with cortical thickness and diminished volume in important areas, such as the cingulate and the prefrontal medial cortex that regulate executive functions, with a strong genetic component. It affects millions of people of both genders, men more than women. It persists to adolescence. It does no, we used to think it resolved. One grew out of it, but we know the brain fully doesn't develop until the 20s. And we know now there's studies to show that throughout adulthood, the condition can pop its head up in a high percentage of cases and then have a negative impact on multiple areas of functioning. So I hope I'm able to enlighten us on the life cycle, but more importantly, the importance of treatment. And you'll be hearing more about that from Dr. Najarian shortly. It's always a pleasure to meet and speak with my colleagues in Armenia. I miss you, and I wish much success with this symposium. Again, many thanks. Bye-bye. And 20